Hi, everyone. Thank you for joining today's community outreach presentation on heart failure, mechanisms, prevention, and treatment, sponsored by CPMC's Kanbar Cardiac Care Center. Today, we are fortunate to have advanced heart failure and transplant cardiologist, Dr. Yu Zi, here with us to discuss the prevalence, risk factors, symptoms, diagnostic testing, and management strategies for heart failure. Before we get started, I'd like to share a few words about the Kanbar Cardiac Care Center. It was originally founded in 2002 at the CPMC Pacific Heights campus and relaunched at the CPMC Van Ness campus in 2022. The center was formed through the generous contributions of the late Maurice Kanbar, who was an inventor, innovator, entrepreneur, but more importantly, a philanthropist. The Kanbar Cardiac Care Center is one of the highest ranking cardiac health facilities in California and offers an array of cardiac services and specialists who use advanced technologies to diagnose and treat patients with heart disease. Its nationally recognized physicians, surgeons, and clinicians are committed to providing excellent, personalized care in a contemporary and welcoming setting. I will now pass it along to Dr. Z to introduce herself and dive into the presentation.
Okay, awesome, Lily. Hopefully you guys can hear me okay and see my slide. I'm happy to see a couple familiar names in the audience list. I see my ECHO team there, which is great. So I'm Yushi. I'm one of the 4 advanced heart failure mechanical circulatory support and transplant cardiologists working at CPMC. We also have additional clinics in other parts of the Bay, in San Carlos, Oakland, San Jose, etc. Today, we're going to be covering a topic near dear to my heart, heart failure. We'll cover the mechanisms, prevention, and treatment in the span of 45 minutes. In order to talk about heart failure, it's important to define it. We'll introduce something called ejection fraction, which is how we measure the efficiency of the heart muscle, the left ventricle. We'll go over a few of the common etiologies or causes of heart failure, how we describe stages of heart failure, talk about what happens when heart failure becomes advanced. Then we'll talk about prevention of heart failure, what we can do to decrease further progression of heart failure, a review of the common 4 categories of medications used to treat this condition, lifestyle modifications, including cardiac rehab, and then some advanced therapies that apply to patients on the very severe spectrum of heart failure. So definitions and types of heart failure. Heart failure is a common and chronic disease in which the heart muscle cannot pump enough blood flow to meet the body's need for blood and oxygen. Common symptoms include shortness of breath, especially with activity or laying flat, which is called PND or paroxysmal nocturnal dyspnea. It can also show up as decrease in exercise tolerance, especially with incline, swelling such as abdomen, lungs, or lower extremity, fatigue, and in some cases, people having early satiety, not feeling hungry, or abdominal discomfort after eating. The worldwide prevalence of heart failure includes over 60 million people globally being affected and 7.6 million alone in the US. Another way to think of it is if among 5 people you know, there's a risk of 1 in 5 of those people developing heart failure in their natural lifetime. We'll briefly review what a heart does in normal function, shown on the right. This is a picture of a person's heart in diagram cartoon picture, as if the person's facing you. So the right side of the person is displayed on the left side of the picture. The right side of the heart, shown in blue, receives blood that's already been passed through the body, extracted of oxygen. So pretend like you're a little red blood cell, shown here. You'll first return to the heart through the vena cavas, shown as 1 and 2, go into the right atria, shown as 3, go through a set of valves, the tricuspid and the pulmonary, and gets pumped out of the right side of the heart into the lung circulation, shown in 7. In the lungs, the red blood cells is going to lose carbon dioxide and pick up oxygen, and then it's going to return to the left side of the heart, shown in red. Here on the left side, we'll first return to the atria, go through the mitral valve, shown 10, And then the left ventricle, shown in 11, which is one of the most important parts of the heart, will first fill with blood, which is known as diastole or filling period, and then squeeze, known as ejection or systole, and pump that blood out through number 12, the aortic valve, out through the aorta, 13, and feed the rest of the body. So when this works normally, which is great, the left ventricle, shown in 11, normally has an ejection fraction of 60%. So EF 60 or greater is considered normal. The way EF is calculated is the stroke volume over the end diastolic volume. Another way to think of it is how much blood gets pumped out of the heart every time the heart beats, which is stroke volume, over how much the heart fills at the end of the filling period. And so if a person has a weak muscle problem of their left ventricle, that's known as systolic heart failure. The medical technical term is HFrEF, heart failure with reduced ejection fraction, which is a mouthful, right? That's hard to say. But you can think of it conceptually as the left ventricle is weak. And so the LVEF is usually less than 40%. Conversely, there's another completely different type of heart failure called diastolic heart failure, which refers to heart failure where the muscle is stiff, does not relax appropriately, sometimes from abnormal thickening, and as a result, blood has trouble flowing into the heart before the heart can send it forward. So these people have a preserved ejection fraction greater than 50% and is called HFpEF, heart failure with preserved ejection fraction. So all these terms are synonymous or written together. There are many different etiologies of heart failure. Heart failure is really an umbrella term, right? It doesn't actually explain the cause of the heart failure, which is the end result. Common causes include coronary artery disease, so the blockages of the artery of the heart that feed the muscle, hypertension, someone who has long-standing uncontrolled high blood pressure. The left ventricle has to pump against that high pressure. It's under high tension, high stress all the time and can fail over time. Valvular heart disease, we talked about the 4 set of valves that a normal blood flow goes across. If some of those valves are either stenotic, meaning they don't open properly, and or regurgitant, meaning they leak, it creates extra blood volume, and pressure causes weakening of heart over time. Arrhythmia, meaning the person has irregular heart rhythm, which can sometimes lead to muscle weakness. And then a totally different condition called cardiomyopathy, where the muscle themselves are abnormal, and I'll show you an example of that, and then congenital. Some people are born with this. And so just to summarize, because this is an important slide, there's 2 main types of heart failure for the purpose of today. The first type is called HFrEF or systolic, shown in the bottom left of the red box, where the heart's dilated, it's weak, the squeeze function is down, the EF is down. The second type is called HFpEF or stiff heart or diastolic heart failure, where the squeeze function is normal, the EF is normal, but the heart's very stiff and it doesn't fill very easily. And as a result, there's increase in pressure. So we'll show you some examples. There's 4. This is the first one. This is an example of a person with systolic heart failure due to ischemic cardiomyopathy or blockages of the artery of the heart, leading to lack of blood flow and muscle weakness. So on the left is a cartoon, shown in light color is the heart. On the surface of the heart, there are multiple coronary arteries, these thin blood vessels that deliver oxygen to feed the muscles of the heart. These arteries at the widest part has a diameter of about 4 millimeters. They're tiny in the overall scheme of things, but they're incredibly important because if they go down, the associated territory that they feed completely gets ischemic or lack of blood flow. Over time, it can weaken or the muscle can be permanently scarred and damaged and does not return. As a result, the heart muscle can stretch, dilate, and remodel over time. There's a couple different types of remodeling. This can over time lead to pump failure, meaning the EF drops, electrical instability, meaning the person might be prone to torsade, VT, other bad rhythms. and cause worsening cycle of heart damage. Also, there's release of abnormal neurohormonal imbalance where different hormone pathways in the body gets overactivated, and that can actually trigger immune and inflammatory changes, lead to more fibrosis or scarring of the muscles, and this is an ongoing feedback loop where it causes more and more problem. This explains about 50% of patients out there with a weak heart problem, HFrEF. The second example I want to show you is HFrEF or systolic heart failure from valve problem. So we talked about the heart has 4 sets of valves. On the right side shown in blue, there's a tricuspid and pulmonary. On the left side shown in red, there's the mitral and aortic. This is an example of a patient with a leaky mitral valve, shown in 10 in the cartoon diagram in the middle top. In the bottom left is a surface echo, a transthoracic echo of a person. Shown in blue of that echo picture is the mitral regurgitation jet under Doppler, meaning we put a special Doppler probe to look at flow, and you can see when flow is going forward or backward, and then you can do special measurements to evaluate how severe it is. When this valve is leaky all the time, there's a lot of to and fro blood, meaning blood goes forward during forward flow, but when the valve closed to prevent backflow, it doesn't close all the way, and so there's a lot of backflow. So that red blood cell is just recirculating to a certain extent. As a result, the heart, the left ventricle, shown in 11, is going to have increased volume, which leads to increased pressure, increased work and stress on the walls of the heart, and over time can cause the heart to dilate and weaken, which sometimes can actually stretch out the mitral annulus and cause worsening mitral regurgitation. So this is an example of leaky valve causing weak heart. In terms of fixing a leaky valve, there's 2 ways to do this via intervention. The more standard or historical way is through surgery, shown on the right, is a surgical mitral valve, either repair or replacement. Shown on the bottom right is a mitral repair, where the surgeon will excise out the redundant or unnecessary part of the tissue, and then cinch it in place with a mitral ring, shown in the half white circle, to kind of give structure to the mitral apparatus. More recent years, there's also something called MitraClip, FDA approved. It's a percutaneous device put in through the vein of the leg. The catheter goes up into the heart to the area of the leaky valve and places a small clip, shown in the picture with the blue diagram, that cinches the 2 leaflets, the front and the back end, the anterior posterior, and then clip them into place, causing one large regurgitant circle or orifice to be 2 smaller ones. There are certain patients that's a better fit for one over the other, but there's 2 surgical or procedural techniques to fix this problem. The third example is not even part of the heart. The initial insult actually comes from the lung. So remember, we talked about a red blood cell goes from the right side of the heart to the lung, then to the left side. Well, if the lung has a problem, for instance, a person has COPD, also known as emphysema, this can lead to pulmonary hypertension, a condition where the pressures in the lung is very abnormally elevated. Now the right side of the heart in blue has to pump against this high pressure in the lung. As a result, over time, you develop right-sided pressure volume overload, and it can lead to right-sided heart failure. So everything before, we were talking about left-sided heart failure, and now you're being introduced to right-sided. And then the tricuspid valve, which lives on the right side of the heart, can sometimes be leaky as a result of this, or actually exacerbate this condition. So on the right is a patient I saw in clinic recently who has tricuspid regurgitation along with pulmonary hypertension. On her, the RVSP, or the pressure measured, was 80, with normal being 25, and she had a pulmonary function test, a PFT, excuse the typo there, that was very abnormal, about 50% predicted. So this is an example of lung problem causing right-sided heart problem. And then the fourth example I want to show you is a heart failure with preserved ejection fraction, or a diastolic heart failure, where the heart muscle is stiff. This is a condition called hypertrophic cardiomyopathy. It's hereditary. It's a cardiomyopathy, meaning there's something wrong with the muscle itself. And so on the right is autopsy picture of a heart that's normal on the right column, and then a heart that has HCM on the left column. You can see that for the person with HCM, the left ventricle muscle wall is much thicker. Normal is about 1 centimeter. These people can have it up to 3 centimeters plus. And then on histo, meaning looking at a slide of the muscle biopsy under a microscope with special staining, shown in the right under panel B, normal have these nice linear striated muscles, versus for HCM, each muscle cell is hypertrophied or beefy, and then there's fibrosis in the extracellular matrix shown in blue. And so these people have a thickened heart muscle. As a result, the left ventricle is stiff, have increased pressure, there's a small cavity, and then people can actually get heart failure from this condition. There's also an end stage form of this where the muscle can dilate over time, and then they end up dropping their ejection fraction, but that's typically seen later on. And then to show you some echo pictures, on the left is an echo of a normal patient. This is an apical 4 view where the bottom of the heart is actually shown in the top of the picture and the top of the heart is shown in the bottom of the picture. The ventricle is the right portion of this. And then you get the sense that the muscle walls are kind of coming in nicely. It's a normal heart. Conversely, on the right, you could tell that it's the same orientation, everything's lined up the same, but the left ventricle is much, much weaker. It does not come in very well. This is a patient who has non-ischemic cardiomyopathy, relatively young, with an EF at the time that measured about 20%, with 60 being normal. But fortunately, on good heart failure medication, he's made a near full recovery. So his echo most recently is much better than this. So we'll kind of keep going. So once you have a patient in front of you or individual in front of you suspected of having possible heart failure, you haven't confirmed it, but maybe they have some of the signs and symptoms we talked about, or they have some of the risk factors for heart failure. The next thing to do is to do some basic testing. The testing are usually done through the medical office. They could include physical exam, getting an EKG, which measures the electricity of the heart and look at the rhythm, getting blood tests, including checking something called NT-proBNP or BNP, which is a natriuretic peptide released by the heart in all of us, but the amount is increased in patients with heart failure or congestion. Next steps include probably getting a basic surface echo, a transthoracic echo, like the video you looked at in black and white on the last slide, to look at the ejection fraction of the heart and screen for other specific causes of heart failure and looking at the valves. Once heart failure is diagnosed, you classify it by ejection fraction into one of these buckets, and then you look for specific causes of heart failure to see what could be reversible or treated, and then you start your patient on heart failure medication. We have typically 4 stages of heart failure. This is how clinicians refer to each other when they talk about how advanced someone's heart failure is. So there's stage A through D, with A being the mildest and D being the most severe or end stage. Stage A is where the majority of your screening and lifestyle modification and prevention comes in. These are people known as at risk for heart failure. They have not developed heart failure. And so these people might have coexisting or comorbidities, things like hypertension, cardiovascular disease, peripheral artery disease, diabetes, obesity, exposure to prior cardiotoxin agents such as chemo for breast cancer, or they might be genetically predisposed. Maybe they have family history of hereditary cardiomyopathy, or they themselves got genetically tested because of positive family history and they carry the gene. But on echo, these people have a structurally normal heart, so they're at risk. That's where the majority of your prevention comes in. If they progress, they become stage B, called pre-heart failure. Remember, heart failure is a clinical symptom. And so these people on echo have a structural heart disease. Their echo shows the heart's already not looking normal, but they themselves overall feel fine. They deny any active symptoms of heart failure. Then if they progress to stage C, these are symptomatic heart failures, patients who have structurally abnormal heart with symptoms, usually on the milder side. And then stage D would be end stage, where patients have either resting symptoms, recurrent hospitalization, something where heart failure is probably the most life-limiting medical condition they have. In terms of trajectory of heart failure, often the way we meet these patients, they already carry a known diagnosis of heart failure. They don't have prior known history. And then we start treating them. They probably presented because of symptoms. Hopefully with treatment, they can have remission, meaning the heart failure improves, the ejection fraction normalizes. And at that point, it's very important to maintain the heart failure therapy because they can have a reoccurrence if they go off the medication. Some of these patients stabilize, but their heart don't normalize. So that would be stage C, shown here in green. And then if a person never improves, unfortunately, they can go on to have persistent heart failure or worsening heart failure. And that's where some of those more advanced surgical options come in, and we'll cover those at the end. In terms of 1-year patient survival, stage A, B, and C all have fairly okay 1-year survival, but when a patient progresses from C, near the end of C, to stage D, their survival curve really drastically drops. And that's shown in the green curve here on the left. So as your survival rate drops dramatically between resting symptoms, mild symptoms to severe resting symptoms, here shown in NYHA class 3 and 4. In red, or the orange dotted line, is showing that they have significant increase in heart failure related hospitalizations. And so as survival drops, hospitalization increases. That relationship makes sense. So we have a acronym known as I Need Help that's developed by the American Heart Association. This acronym stands for I for IV inotrope, meaning a patient in the hospital needing continuous IV infusion of medication that increase how hard their heart can work. This is only a temporizing measure. Patients who have advanced disease, so NYHA 3B or 4, meaning a lot of symptoms. E for end organ dysfunction, they start to have abnormal kidney or liver function. E for ejection fraction being even worse than 40, so less than 35. D for their defibrillator shocking them, so they have abnormal rhythm causing their defibrillator to go off, maybe VT. H for having heart failure hospitalization more than once in the past. E for edema, meaning swelling despite increasing doses of diuretics or water pill to help them pee. L for low blood pressure and high heart rate. That's a way for the heart to try to compensate, right? As the stroke volume or cardiac output, stroke volume drops, you try to maintain cardiac output by maintaining an adequate heart rate, meaning if each time the heart beats, it doesn't send very much blood forward, you compensate by bumping up the heart rate. That's usually not a good sign. And then P for prognostic medication or progressive intolerance, or down titration of guideline-directed medical therapy, meaning a patient who used to be stable, maybe their beta blocker and ARNI, which we'll go over later, but because of worsening low blood pressure, worsening renal function, dizziness, we've had to decrease medication they were stable on for some time. So I Need Help is an acronym to remember that, hey, a patient who was previously stable, maybe on stage C, is now perhaps progressing to stage D, and that's a warning sign to the patient, their providers, or family that, hey, we need to do more to try to perhaps rescue them. So the goal is to reduce heart failure hospitalization and pick up on these signals early. And the 1-year mortality for stage D heart failure is comparable to the most aggressive cancer, but we don't always think of patient presenting with stage D heart failure first time as having as morbid of a diagnosis as maybe pancreatic cancer, but we should take it just as seriously. In terms of heart failure prevention, that we talked about, the goal is really once a person has known pre-existing conditions, shown in the bottom left in green, really to hone in on the management, optimization, risk minimization of all those things, and then keep regular follow-up so they can be screened. And so we'll go over each of these in individual slides, but we'll talk about how to screen, minimize, and treat for each of these things. And then there's 2 things I'll also pay attention to under screening. One is the NT-proBNP, which is a blood test of a natriuretic peptide, and then coronary calcium CT scan. So in terms of exercise, the American College of Cardiology and American Heart Association recommend 150 minutes of cardio, moderate intensity exercise per week in zone 1 through 3 on the right. Alternatively, they said you could do 75 minutes of vigorous aerobic exercise per week in zone 3-4. So 4 is in orange, right? That's where companies like Orange Theory gets their name. So they try to rev you up to this vigorous aerobic exercise. But you could do this in any fashion. You could do 3 days of 50-minute, 5 days of 30 minutes or some combination, or more the better. But I'd ideally try to maintain at least 150 minutes per week. Examples are brisk walking, running, swimming, cycling, playing tennis, jump rope, something that gets the heart pumping. And then more basically, I tell my patients, you should feel somewhat short of breath. You can maybe say some short sentences or phrases to the person next to you, but if you're talking in full sentences, you're probably not exercising hard enough for it to count. And then, for people with busy lifestyles, personal life, work life, it's hard to exercise on the regular. When I interview my patients who are very dedicated and able to do it, a lot of them say they just commit to putting it in their schedule and usually trying to attack it first thing in the morning before the rest of the day becomes more either unmanageable or unexpected things come up. And then some people really enjoy having an accountability buddy, whether it's a walking group or having an app that tracks their success so then they can check each other's with their friend. There's a lot of ways to try to inject a little bit of fun into this. And then number 2 is nutrition. It's hard to talk about nutrition without talking about Mediterranean diet and intermittent fasting, but those are not the only options. Mediterranean diet refers to a mostly plant-based diet, meals that are focused around vegetables, fruit, herbs, nuts, beans, and whole grains, healthy fats like olive oil, moderate amounts of seafood, dairy, poultry, and eggs, rare red meat, but it's not culturally representative of everyone, not even half of the people. And so I try to tell people to avoid eating highly processed food, try to prepare meals if it's at all possible, try to eat real food that quote unquote our grandmother can recognize. And then also there's a study that said if people can eat slower, recommended to take at least 20 minutes or more for your meal, compared to people who eat fast, less than 10 minutes, those people tend to have less weight gain problems just by chewing longer and eating slower. There's also this Japanese term, hara hachibu, that means eat until you're 80% full. So not eat until you're full, but eat until you're just starting to not feel hungry or very slightly full. And then, there's a dietitian I really enjoy listening to, and she says there's this hunger crushing combo, meaning how to stay satiated. And we try to focus meals that have protein, fiber, and healthy fats to try to stay satiated longer after eating. And a simple comparison might be processed cereal versus oatmeal that maybe has a scoop of peanut butter in it. And then finally, think of these as, let's say you enjoy pasta, it doesn't mean you can't have it, but perhaps add some additional cooked vegetables into it to bulk it up and make it healthier with more fiber, instead of saying, oh, pasta is a bad food, I need to avoid it, that kind of thing. I also listed here this little cartoon. It's a raccoon that says, at workouts, I can eat garbage, which I thought was pretty funny, just to remind us that it's exercise, nutrition, lifestyle all together. It doesn't mean you could do one thing perfectly and then kind of not be mindful of other things. And then Michael Pollan's a very popular author who talks about diet, nutrition, and our health pandemic. Intermittent fasting. So some people really believe in intermittent fasting, and it's been shown to have a lot of benefits. It's based on choosing regular time periods of eating and fasting. The mechanism is to cause your body to metabolic switch. During periods of extended fasting, the body exhausts its sugar stores and start burning fat. If a person's used to eating multiple small meals throughout the day, then they potentially never reach metabolic switching, so they don't do the fat burning phase. An example that's popular would be daily intermittent fasting, where a person eats for 6 to 8 hours per day and then fasts for the remainder. A different option is a weekly schedule, where a person on 2 days a week do a more strict fasting, where they eat only one regular meal, and the other 5 days they don't do intermittent fasting, they eat per usual. During periods of fasting, typically 0-calorie beverages and water are okay, and during periods of eating, they say don't try to consume excessive calories, just eat to comfort and still focus on regular healthy meals. Research show that the first 2 to 4 weeks when people switch to intermittent fasting, they often don't love it. They might feel hangry, so to speak, but often it might take them a couple weeks for their body to get used to it. And in fact, a lot of people in these observational studies report improvement in cognition, health, heart, heart health, excuse me, physical performance. And then when they measure people's glucose control, weight, there's been reported improvement. And then some people report they feel like they recover faster from exercise. There's exceptions to every rule. So people who should not do this or should do this with caution are people who are extremes of age, people with liver issues, diabetes, especially type 1, pregnancy, lactation, eating disorders. And some people do more extreme versions of this where they fast for multiple days, and that's usually considered not better and maybe dangerous, and may encourage the body to go into starvation mode and actually sequester and keep on weight. So we covered lifestyle prevention, and then I want to talk about screening. Given coronary artery disease is so common, and it's one of the most common causes of heart failure, screening for coronary artery disease is relevant to a lot of people. One screening option considered is coronary artery calcium CT scan. This is a heart scan. It's basically a three-dimensional X-ray. It's non-gated, not done with contrast, meaning no IV, no contrast, doesn't affect the kidney, and it's just of the heart. So it doesn't involve the rest of the body, relatively low radiation dosage. And it looks for calcified plaque or hardened plaque in the artery walls among asymptomatic individuals. And it's recommended more for people middle age, so not the extremes of age. If present, if plaque is found, then the person has coronary artery disease. The result is reported with an absolute score, meaning how much hard plaque there is, and a percentile adjusted for age and sex, so you know where you are relative for your age group. Shown on the bottom right is an example of 4 different individuals with 4 different coronary calcium scores. The bottom left is someone with no plaque, so you don't see any white spots. The second is someone with mild plaque, so see the tiniest little white plaque there. The next one is someone with moderate plaque. You start seeing quite a bit of calcium. That's the bright lines. And then the last example is someone with a significant calcium where you see the lines take up the majority of the shape of the LAD in this scenario. And so once a person has a scan, it can give us a score and a percentile and help guide the level of subsequent screening, maybe echo, stress test, EKGs, how aggressive you want to be with prevention, for instance, lipid management, and diet and exercise. If a person has a score of 0, meaning no plaque, it puts them at the lowest risk category of having future heart and stroke disease in the next 5 years. And this is very well demonstrated in a large population study called the MESA study. But the thing to know that this is not necessarily covered by insurance. And so some patients elect to get this done out of pocket. In the right patient population, I do think this is a very helpful test. This is to show you what the cross-section of a coronary artery looks like. So this is those 4 millimeter in diameter small arteries that live on the surface of the heart that send blood flow to the heart. On the left is someone who essentially has a normal artery and normal lumen, meaning the space inside, but the wall is starting to have very slight macrophage or immune cells that show up, and the person has no calcium. So this would not show up as abnormal on a calcium scan. Progressively, people can have more small pools of lipid or fat deposit. As the pools get bigger, there can be some calcium in the walls, and there can be fibrous thickening. And then finally, if this wall becomes thinned and the lipid pool in yellow becomes large, sometimes it becomes unstable, and you can have thrombus that leaks out, and that can cause propagation of a clot, and that would be what an acute myocardial infarct or heart attack is. And so in each of these, as it progressively gets worse, there should be usually more calcium present, but not always. And so a calcium scan would give us some inkling of how much this is present. Here on the right bottom is MESA result. That's that large study we talked about. So the MESA was the first NHLBI sponsored prospective cohort study. So that's National Heart Lung Blood Institute, to study and address the incidence and prevalence and progression of patients with asymptomatic or subclinical cardiovascular disease. So these are all individuals who feel fine. They don't have chest pain or pressure. And they saw that for each increase in calcium score category. So going from each of these colors as you go up, for every decade of life, they saw there was an increase in heart disease related to higher calcium score. And so these days, when we see a patient in front of us, we consider them sort of in combination of their traditional population-based risk factors, whether that's their age, gender, prior smoking, cholesterol, et cetera, but then also this personalized medicine, right? Disease-based risk prediction, including using things like the MESA score. And so this is what the MESA calculator looks like. Your doctors may even pull this up during a visit and punch in your numbers to show you what your risk score is. So I made up a general patient, 50 years old, with a little bit of calcium score of 100, no diabetes, no smoking, no family history of heart disease. Sounds pretty good. A little bit of mild hypertension, blood pressure 130s, a little bit of high cholesterol, but not even that bad. And then because of the presence of calcium and hypertension, this person has an estimated coronary age of 74, even though their actual age is 50. And so when I pull something up like this, it's not to scare the patient, and hopefully, that's not my intent, but it probably causes some anxiety. But the benefit is it starts a discussion about what can we do to decrease your future risk. Because sometimes there are scenarios where people are reluctant to start medications if they're asymptomatic. So we talked about how to screen for CAD. How do you treat it? So once a patient has confirmed diagnosis of coronary artery disease, especially if there's significant plaque or even flow limiting disease, then we usually put them on baby aspirin, a statin to lower their cholesterol, potentially if they have angina, also beta blocker, nitrates, and then exercise programs. So dedicated formal cardiac rehab and also just regular exercise on their own, all shown to improve survival and outcome. If the plaque is causing severe narrowing to the point that blood flow doesn't flow normally, a person might have shortness of breath, angina, low heart function, then you want to revascularize them, often either with a PCI, which is a percutaneous stent put in through a catheter through the leg, or through CABG, bypass surgery. And these days, instead of a full sternotomy shown in the bottom, where there's a cut made vertically along the length of the sternum, some patients might be able to get away with what's called a mid-cab, a minimally invasive direct CABG, where the incision is made as a lateral thoracotomy, a mini thoracotomy, and the incision is smaller. And then in the right middle there is showing you how bypass grafts look and work. So essentially, taking an artery or a vein and basically causing an additional pathway of how blood can go from one of the branches of the aorta to the artery that has the blockage, attaching it distal or downstream from where the blockage is, essentially bypassing the area of narrowing. And there's scenarios where one option is better than the other for patients. To switch gears a little and talk about medication treatment specifically for HFrEF. So there's lifestyle, and we'll go over those. There's 4 categories of medication. So this is where you're being introduced to beta blockers. ARNI, ARB, and ACE inhibitors are considered one class altogether, MRAs, and finally SGLT2 inhibitors. A patient might need diuretics, and then if they progress from stable heart failure to unstable, or they have really severe disease, we start talking about defibrillators to prevent sudden cardiac death, sometimes valve interventions, sometimes if they're in cardiogenic shock, they need to put on temporary machines to support their blood flow. These are usually done in the ICU only. And then finally, if they don't recover, we sometimes would put them through evaluation, and they would undergo a durable LVAD or heart pump that they leave the hospital with, or be listed for heart transplantation, where surgeons take out their old heart and put in the heart of a deceased donor. And so to talk about heart failure treatment, it always starts with lifestyle. Maybe 30% of my visit is always focused on lifestyle, especially with patients with a new diagnosis. In general, the heart does this abnormal thing where it's dilated, stretched out, weaker, congested. The kidney sees relatively less blood flow, and as a result is confused and think there's not enough blood volume. As a result of this and some other things that we won't go into, the kidney is going to abnormally sequester excessive amount of salt or sodium, and as a result, excessive amount of fluid. So your heart failure patient is going to have a tendency to retain fluid and salt. So as a result, you want to tell them, try to keep your salt at a minimum 2 grams per day or less. Average American diet is 4 grams. And try to keep euvolemic or relatively normal fluid status. For most people, that's 2 liters. And then check their home weight, blood pressure, and heart rate daily and keep a log and bring the log to clinic. Also, HFrEF patients would usually be qualified for cardiac rehab. If they smoke and that was thought to cause their CAD, we would tell them to stop smoking if possible. And then if they are have significant alcohol, which is a direct cardiotoxin, we would tell them to try to minimize or cut it out. And some patients' heart failure is from ingestion of toxin. For instance, there's a huge meth epidemic. We would try to tell them to minimize that as well. And in some cases, we'll see near normal recovery just from cessation of the toxins and with medication. Cardiac rehab is commonly prescribed but frequently underutilized. And so 29% of patients prescribed and approved for cardiac rehab who are Medicare beneficiaries over age of 65 actually make it to the first session. This is less than a third. And only 8% actually complete a full 36 sessions. So the majority of people who could benefit are approved and insurance paid, unfortunately don't attend it. Cardiac rehab is 36 one-hour sessions done over the span of about 2 to 3 months. It's in a monitor setting with nurses who can monitor vitals, do EKGs, and then lead exercise classes for the patients. And it gives them, I think, emotional support as well. There's underutilization among women compared to men counterparts, and there's underutilization in non-white individuals compared to white counterparts as well. This is a slide, it's a little busy, but it shows you the most recent 2022 American Heart Association guideline-directed medical therapy, meaning what drugs do we put people on for patients with heart failure with reduced ejection fraction. So we'll go over each of these categories in the next slides. And to summarize the most recent guideline, there's a couple take-home points, the most important in bold. So we'll go over the 4 classes shown here. They said even if a person improved their ejection fraction, previously had a weak heart, now recovered, they should still continue their treatment. And then it's important to refer to an advanced heart failure team. We talked about the I Need Help acronym to keep in mind when your patient's progressing from sort of mid-heart failure to end-stage heart failure. You want to rescue them early because of that very poor prognosis. And then primary prevention for individuals at risk in stage A or pre-heart failure is really key to prevent those patients from progressing into end stage. This shows all the compensatory effects of heart failure. So when the person has a weak heart, there's multiple compensatory pathways in the body that gets revved up. In short term, they're helpful. In long term, they actually cause more problems. So for instance, the renin-angiotensin-aldosterone antagonist pathway gets revved up. The body also does something called vasoconstriction. So the body sees less blood pressure. So the arteries actually constrict or tighten to augment and increase blood pressure, preserve blood flow to vital organs like brain, lung, kidney, heart, but actually decrease blood flow to non-vital organs that are still necessary. There's also rev up of sympathetic nervous system, so that's your adrenaline being on. And then there's also abnormal vasomotor activation. And so we talked about adrenalines being overly activated. So beta blocker, one of the cornerstones for decades for heart failure, is recommended because it blocks some of this excess adrenaline and noradrenaline. There are 3 beta blockers that are recommended for heart failure: metoprolol succinate, probably the most commonly prescribed, carvedilol, and bisoprolol, and they're considered relatively comparable. Indication for people with weak heart muscle, HFrEF, but also for people with lack of blood flow causing chest discomfort, angina, certain types of arrhythmia, and high blood pressure. Because it can lower blood pressure and heart rate, side effects include dizziness, fatigue. Some people do have weight gain and abnormal dreams, and it can cause low blood pressure. And in men, it can increase erectile dysfunction. The benefit and the side effect of beta blockers are dose dependent, meaning the higher the dose, you're more likely to see it. In research studies, the higher dose portend a higher improvement in mortality and morbidity. And so the key when we use these medications is to go slow and steady and titrate the doses up. Often we double the dose at every visit. So for instance, on Metope, you might start someone at relatively low dose, 25 or 50, and over the span of a couple months, you might be bumping the person up to maximum dose of 200, assuming their body can tolerate it safely. You don't want to start at 200 because most people wouldn't tolerate that. The second class historically were ACE inhibitors and ARBs, but now has addition of ARNI, which is a new drug in class that I'll go over in the next slide, are afterload reduction agents. They work by decreasing the blood pressure, so they're also used as hypertension medications to treat hypertension, so that the weak heart pumps against a lower resistance or lower systolic blood pressure, and so it can augment stroke volume. The heart can have an easier time sending blood forward. And so ACEs work on preventing an enzyme in the body from making angiotensin II, which is part of this pathway here. You don't have to know all the specifics. And then ARBs, which is a similar category of medications, work at inhibiting AT1. ACEs work on inhibiting ACE in the lungs, shown in two spots here in the diagram, but they work overall on the same pathway. And so they block the mechanism of abnormal vasoconstriction, excess aldosterone production, excess salt and water retention to help with some of those deleterious compensation that the body makes that we talked about. ARNI, also known as angiotensin receptor neprilysin inhibitor, is a new drug in class, meaning prior to this, there was no other medication approved in this category. It's been FDA approved for the treatment of heart failure with reduced ejection fraction. It's a combination drug, meaning it has two components, sacubitril and valsartan. Sacubitril is a prodrug. Sacubitril works by inhibiting the breakdown neprilysin, causing longer half-life or more neprilysin circulating, which causes a beneficial property shown in the bottom left box of vasodilation, which can cause decrease in blood pressure, decrease in sympathetic tone, aldosterone, decrease in fibrosis and hypertrophy, and augment natriuresis and diuresis. Valsartan, which is an ARB, which we talked about earlier, inhibits on the right pathway, so actually prevents what's in the right bottom blue box. So it prevents vasoconstriction, excessive high blood pressure, sympathetic tone, high aldo, fibrosis, and hypertrophy. So this is now approved for heart failure with reduced ejection fraction and is slightly preferred over ACE inhibitors and ARBs if possible. The third class is in the category of MRA, mineralocorticoid receptor antagonists. There are two medications in this class, spironolactone and eplerenone. Their mechanism is they're an aldosterone antagonist, and they work in the kidney. They prevent the kidney from having as much salt and water reabsorption. So they help with diuresis. They also increase potassium retention. So we have to check our patient's labs to make sure their potassium's okay and their creatinine's okay. It's also been shown to reduce overall mortality and hospitalization for heart failure. It can have side effects, including gynecomastia, where male patients develop tender breast tissue enlargement. It can cause GI discomfort, and we talked about the renal electrolyte abnormalities. And then the fourth and final category are SGLT2 inhibitors, also relatively new. It's a medication that's a sodium glucose co-transporter. It works at the kidney level. It affects the SGLT2, which is a co-transporter, and causes glucoseuria, loss of glucose in the urine, and diuresis, loss of fluid in the urine. So it causes your patient to pee more, and their pee contains glucose. One thing to remember is if the patient has a urinalysis checked, some patients, if they don't know that they're on SGLT2 inhibitor, they might think that they have diabetes that's really not well controlled. Side effect includes certain genital urinary infections because of the glucose. For patients who, tolerate these medications, great. For patients who progress to end-stage heart failure, I just have two slides on sort of the extreme of cases. This won't apply to nearly everybody but heart transplantation was first conducted in 1967 by Dr. Bernard in Africa. And this is a picture But nowadays, it's advanced significantly. The surgical anastomosis technique, meaning where the surgeon makes a cut, is different now. Shown on the left, there's 5 incision points they make, where they disconnect the old heart and then re-anastomose or connect a new heart. So the vena cavas, the aorta, the pulmonary artery, pulmonary vein. And then we have these heart in a box or DCD, where a heart's being preserved to allow longer ischemia time. In other words, for a patient to be able to receive heart donation from farther distance. And then finally, for patients who maybe transplant's not a good fit, or they're not approved for heart transplant, or they're not stable enough to wait for a heart transplant, an LVAD HeartMate 3 heart pump is a durable machine heart that a patient can get implanted into the chest. There's a small pump that rotates, is a full maglev motor, and blood goes through, gets pulled out through the left ventricle into the pump, and then bypasses part of the heart and gets put in through the aorta to send more blood flow to the patient. The benefit is the patient will have improved survival, outcome, functionality. The potential downside is that for a lot of people, this is quite an extreme mentally to kind of grow used to the idea of. And so we have tons of patients who's undergone this surgery. Sometimes when a patient's being evaluated for either options, we'll talk to them, have them meet a patient, maybe virtually, who's gone through something like this before, so they can ask a lot of questions about what quality of life is like and what their everyday is like. And an LVAD has to run on continuous electricity, so there is a cord that comes out of the abdomen of the person connected to a controller and a pair of batteries, approximately 5 pounds total, that a person will have to be connected to if they're walking around. If they're stationary, they can be connected to a long extension cord to the wall. And so I'll end on this slide. This is a review of everything we covered today in our 45 minutes together. Heart failure is a chronic condition, very common. 1 in 5 adults would develop it. A normal heart ejection fraction is 60%, not 100. There are 2 major categories of heart failure: HFrEF, which is a weak muscle, and HFpEF, which is a stiff heart. And heart failure is an umbrella term. There's many different etiologies that we reviewed. Screening for heart failure and the risk factors for heart failure is key. That includes regular exam, blood tests, in certain situations, specific screening CT scans. And then prevention is key. There are 4 classes of medications for heart failure: beta blockers to decrease the adrenaline, ACE, ARB, and ARNIs for afterload, mineralocorticoid receptor antagonists for the hormonal blockade, SGLT2 inhibitor for the glucosuria and diuresis, and each of them offer additional morbidity, mortality benefit. And when a patient recovers, they still ought to be on at least some of these medications. And then in extreme of cases, there's additional surgeries and procedures for patients with advanced heart failure, including LVAD and heart transplant. And I'll end on that.
Alrighty, so I have a few questions that were submitted prior to the presentation, which I'll go ahead and start getting into. And then if we get any questions in the chat or Q&A, we'll do our best to address those as well, though we just have a few minutes left. First, I have a question that says, why do I get dizzy walking uphill and stairs on daily metoprolol 50 milligrams? No issues exercising on flat surfaces.
Yeah, so when anybody, not even a heart patient per se, goes up incline, that metabolic level, we call it MET, is actually significantly more than what walking even briskly on flat ground is. It's just a higher metabolic challenge. And so if a person have limiting symptoms from their heart failure, class of way we ask is, you know, how fast can you go up a flight of stairs? Can you do 2 flights of stairs? Can you go up an incline? So incline stairs are just much more challenging than flat ground, even if you're going at a brisk pace. I don't know the specifics of this person asking the question, like what their blood pressure is or EF is, but often, you know, if a person has very advanced heart failure, sometimes they can't tolerate a certain dose of beta blocker, and they might have to actually go down on dose. If a person has relatively slow heart rate, sometimes the beta blocker is decreasing their heart rate further, and that might be an issue either, you know, from a rhythm perspective or a beta blocker dose perspective. Often we try to tease apart how limiting is the dizziness. If it's relatively mild, if they go up the stairs a little slower, it's non-limiting. We usually tell them to try to still do it because exercise is so good. But if it's very limiting, they're nearly passing out, then they definitely need to kind of get reevaluated on that medication.
Got it. Thank you, doctors. Next, how long can an LAD stent implant last in a 55-year-old male generally?
Yeah, so an LAD is one of the most important coronary arteries. It stands for left anterior descending. It's the one that feeds the front part of the heart. In that diagram, it was the one I put an X on. So it's very crucial. Not all stents are equal, so there's multiple generations of stents, and currently the most updated type has very, very good long durability. But even among that, there's still patients who tend to have their stent go down or restenose more so than others. And the risk factor for that is very similar to the risk factor of getting coronary artery disease in the first place. So diabetes, especially not controlled, active smoking, high cholesterol that's not managed, and to a certain extent, some people are just more prone to it. But we definitely have had patients whose LAD stent lasts them indefinitely, and then we still seen patients who restenose despite the best intentions by them and their doctors within a few years. And so sometimes a stress test might be the way to assess that out, or some patients will need a repeat angiogram to recheck the stent. That's usually only done if they have symptoms.
Great, thank you. Next, we already got into the most effective medications, but the tail end of this question asks if there are any new treatments on the horizon.
Sorry, regarding medications was the question?
Yes, the question is regarding medications. If you don't mind reviewing those, they also ask if there are any new treatments for heart failure on the horizon.
Yeah, of course. So the 4 category of approved medications for weak heart, HFrEF, are those 4 that we talked about, which are beta blockers, afterload reducing, including ACEs, ARBs, and ARNI, mineralocorticoid receptor antagonist, and then SGLT2 inhibitors. Of those, ARNI and SGLT2 inhibitors are actually relatively recent drugs that came on for this indication within the last handful of years. Prior to that, for over a decade or two, we've essentially had no new development medications. So in the heart failure space, this is actually already very exciting for us. So to give you an example, when I was in training, those 2 new drugs weren't even available. And so likely there's going to be more SGLT2s that's made available. And likely currently there's only ARNI Entresto available, but there's going to be other ones in that category. And there's a lot of other research trials hitting each part of that hormonal pathway that we talked about, but nothing immediately in the next 6 to 12 months that's a new category of medication that I'm aware of.
Got it. Thank you for sharing. It's helpful. Next, this question asks if there's a test for atrial fibrillation, and it sounds like there's a family history. They ask if they can be tested without symptoms.
Yeah, of course. So approximately, so just to rephrase, so AFib, atrial fibrillation, is where the top half of the heart beat in an irregular way called AFib. It has a hereditary component. It's more common as people get older, and there's some risk factors for it. About half of people with AFib don't feel it, so they're asymptomatic, so absolutely can happen. The most definitive way to check would be to come into the office and get a 12-lead EKG. But these days, there's a lot of personal smart devices out there that can do it. So the Apple Watch that has EKG capability, AliveCor has one. We don't have affiliation with either, but these are the 2 we commonly recommend to patients. And then if a person wants a longer-term monitor for it, sometimes people get a Zio patch or heart monitor, and those are like essentially a single lead EKG monitor that goes with them for X number of days to see if they have intermittent AFib during that period. Those will be the ways to definitively check for it.
Great, thank you. Next, can you discuss the difference between a heart scan and coronary CT angiogram?
A heart scan, also known as a coronary calcium scan, is no contrast, non-gated, meaning there's no IV, no contrast injected. It's a quicker scan. It's also less expensive, and it's considered for screening in asymptomatic individuals. A CT angiogram is where they put in an IV, they inject some contrast, which is clear through the kidney. So if someone has kidney dysfunction, it's something to be concerned about. It's gated, the heart rate needs to be controlled in ideally regular rhythm. And as the contrast goes through the blood and goes through the arteries of the heart, the CT scan will capture that and show us if the arteries are open or closed. So the first scan shows us, does the wall have plaque that's hardened? Doesn't tell us how open or closed the arteries are. The second scan you do usually in symptomatic individuals or people with heart problems. You do with contrast, it's gated, the heart rate needs to be controlled, and it actually shows how open or closed the artery is. We usually use the second scan in people with significant heart issues, and the first one's more like an asymptomatic screening test.
That makes sense. And I just have one more question here, if you don't mind answering it. I know we just hit 5 o'clock.
Yeah, no problem.
Would diet delay weak muscle as well as stiff muscle problems, or either or?
Will diet delay, was that the question?
Yes, I'm assuming diet interventions.
Yeah. And so, we usually try to tell our patients it's more a lifestyle or a way of eating rather than quote unquote dieting, because that word has a lot of connotation. But essentially, I think keeping a healthy diet will help decrease a lot of those metabolic syndromes that are potential contributors to developing heart failure. But do they specifically reverse heart failure? Or do they specifically delay it by X number of months or year? I think that's hard to pinpoint, but I think they will make the person overall healthier, have less metabolic syndrome, which can cause a lot of other comorbidities, whether it's vascular disease, stroke, heart disease, and overall improve their heart function. But does it specifically delay heart failure? It's hard for me to say, there's a direct correlation.
Great. Well, thank you. That brings us to the end of our Q&A. I just wanted to thank everyone for joining the Kanbar Cardiac Care Center for this presentation. And thank you to Dr. Z for taking the time out of your busy schedule to present on such an important topic. Kanbar Cardiac Care Center will continue to host community education events related to cardiac health every other month. So keep an eye out for emails regarding upcoming presentations. Thank you all again and have a great evening.